Just to let you
Hi,
know,
Guy.
you're live now.
Good morning.
Hi there. Everybody, good morning, and thanks for being here. So we are just going to wait another 1 or 2 minutes, and then we'll start. A couple of people are having some problems with their links, but we'll be starting in 1 minute. Okay, everybody, it looks like we're about ready to get started. So I am gonna, I know we still have a few people joining, but maybe I can turn it over to our chair, Guy Palmer, for some welcoming remarks as people continue to join us.
Sure, thank you, Joanne, and good morning, everyone. And again, I want to just really share my appreciation for your willingness to either serve on the committee or present to the committee, and also for the work of the staffers at the National Academies. It's just always a challenging time, and it's a new experience for many of us in many parts of our lives to do everything virtually. We do have the joy occasionally of having a dog bark, or we almost had a chance of a ukulele lesson yesterday. So there are little joys that come with virtual life. But again, I just want to appreciate everybody being here. As chair of this study and of this committee meeting, I'd like to again welcome you. The task being undertaken by the committee of the National Academies includes commenting on progress against the national strategy of combating antimicrobial resistance. And this full task is available on the study website. As far as today, I want to note that this is an open, on the record session. Interested individuals and members of the press may be attending as observers. While this is not a news conference, and we will not be entertaining questions from the floor, reporters who would like to speak with committee members are asked to touch base with Jillian Buckley, who is the study director, and her contact information is posted at the study website. I'd also like to remind everyone that this is an information gathering session today. That is, the committee is in the process of assembling materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask that everyone today be extremely mindful that the committee has made no conclusions, and that it would be really an error for anyone to leave here thinking otherwise. Comments made by individuals, including the committee members, shouldn't be interpreted as positions of the committee or of the National Academies. In addition, committee members are encouraged to ask probing questions in these information gathering sessions that may not be indicative of their personal views, the committee views, or anything that will come into the conclusions and recommendations. The committee will deliberate thoroughly before writing its report. And moreover, once this draft report is written, it does go through a secondary rigorous review by experts that are anonymous to the committee. And the committee then must respond to those reviews with appropriate revisions that satisfy the National Academies Report Review Committee and the National Academy of Sciences president before it is considered a National Academies report. So very much we're at the early stages of this, and any comments or questions should not be interpreted as positions at this time. So Joanne, I don't know if you have anything to add to that before we jump into today's program.
I don't have anything to add, but do you think I can, maybe we can start? I know time is going to be tight today. So I guess I'd just like to start by introducing Jane Knisley from National Institute of Allergy and Infectious Disease. Jane, I know you're on.
Yes, I'm here.
Super.
Oh, okay. There she is.
All right, I have Jane's slides, and I am going to, sorry, and my apologies, to present these. So bear with me for one moment as I share my screen. Okay. There we go. Is that working for people?
Yes, thank you. Okay. Well, so thanks, Jillian, for the introduction. I am Jane Knisley. I'm a program officer in the Division of Microbiology and Infectious Diseases at NIAID. And NIAID is the sponsor for this study. And so it is my job today to present the orientation to the statement of task. Next slide, please. So the outline for my talk today, I'm going to describe the impetus for this study, the key, go into key background information. Yes, that will be hopefully of value to you as you set about your task. Some key points that my colleagues from the Interagency and I feel would be opportunities for this committee to add value to the vast body of work that has already been done on this topic. And then finally, a question and answer session. And I really hope that my interagency colleagues will be available to chime in during that. So to the impetus for the study, in our appropriation bill this year, we received this language that we were to fund a National Academies study. So this is really coming from Congress to examine and quantify the long-term medical and economic impacts of antimicrobial resistance in the US, including examining progress on the National Strategy and Action Plan for what we affectionately refer to as CARB, combating antibiotic resistant bacteria, and to make recommendations to address gaps in the areas that you see here. Next slide, please. So I just wanted to touch on a few things that will be really important for you to at least be aware of. I'm sure you're already aware of the National Action Plan for Combating Antibiotic Resistant Bacteria, and we'll have a whole talk on this coming up, so I won't spend much time on this slide. Just suffice it to say that we are at the end of our first National Action Plan, and our new National Action Plan is slated for release in the coming weeks, and signals the continued commitment that our agencies have to the CARB challenge. Important to note that there are progress reports that the CARB task force issues to this National Action Plan on more or less an annual basis. So that'll be a good place to look and find out our progress on the activities described in the action plan. And noted at the bottom here, I'm sure Michael Craig will go into depth on the CDC's antibiotic-resistant threats in the United States. They, of course, it was sort of a groundbreaking report when it first came out in 2013 and then again in 2019, highlighting the urgent, serious, and concerning threats in the US. Next slide, please. Another part of CARB that was also included in the executive order that established that there was to be a national action plan and a task force was the creation of a federal advisory committee called the CARB, Presidential Advisory Council on CARB. This council reports to the Secretary of HHS and is comprised of 15 voting members that are roughly split between the human health side and the animal agriculture side, as well as a number of liaison representatives representing industry groups or professional societies, as well as what are called regular government employees. These used to be known as ex officios, and that's kind of us, the people from the agencies who can serve on the PAC-CARB and sort of inform their work. We don't vote, but we inform their work and let them know what's going on with our agencies. And between 2016 and 2019, the PAC-CARB has been very busy. They've produced 4 reports that contain quite a few different recommendations, and so I've listed you for them here, as well as the website where you can find all of this information. So important to understand the work that has come before. Next slide, please. Also, just as of earlier this year, there was a Government Accountability Office report. Again, this was requested by Congress. Focused on antibiotic resistance and the US government response to the issue. GAO took a comprehensive look at agency progress on antimicrobial resistance in human health. Animal agriculture was not within the scope of this report, and they did make 8 recommendations of diverse nature. Next slide, please. So moving away from the government side, but still in the US, the Pew Charitable Trust has an antibiotic resistance program project, which does a lot of great things and has a lot of great resources available on their website. So they do work on antimicrobial stewardship. They also have been housing a clinical pipeline tracker for antibiotics and more recently non-traditional therapeutics. So candidates that have reached the clinical development phase. There are interactive graphics there that are really nice to look at the state of the pipeline. They released a report on gram-negative drug discovery several years back that I will reference in my talk on NIAID's response to CARB National Action Plan. They have a data sharing platform for antibiotic structures called SPARC that is really of use to the research community. And they've also done some work on incentives, which I will, I'll talk more about incentives towards the end of the talk. Next slide, please. Also in the US, on the animal side, the AVMA recently released this report that you see on the screen. This was the first report describing the current status of antimicrobial resistant bacteria affecting various animal species in the US. And it includes easy to review summaries of antimicrobial bacteria affecting the wide range of species. This has been something that's been eye-opening to me working on the CARB task force and the PAC-CARB, is just how complex the animal agriculture issue is, because you have species that include dogs, cats, horses, cattle, swine, sheep, goats, turkeys, fish, and shrimp, and all different pathogens and antibiotics to consider there. And this report also includes resistance profiles for each of the bacteria identified in the report. Next slide, please. So the TATFAR, the Transatlantic Task Force, has been around since 2009. This is a group that originally was comprised of the US and the European Union, the European Commission, and really was a way for us to communicate and collaborate to work more effectively on the issue of antimicrobial resistance. We've since added Canada and Norway to our membership, and you can see the key focus areas here on improving antibiotic use in humans and animals, preventing infections and their spread, and strengthening the drug pipeline. And if you go to the website, you can see the reports and the current 5-year plan that the TATFAR is operating under. We are in the process of developing the next 5-year plan. That was delayed a little bit due to COVID, but should be out in the next year or so. Next slide, please. So now moving more to the international realm, several years back, the UK government commissioned this extensive review on antimicrobial resistance. And this was chaired by Lord Jim O'Neill, who is an economist. He was formerly at Goldman Sachs. And you can see that they're very prolific. They released 9 publications on a diverse array of topics. And they conducted some modeling, which produced this, this figure that you see here, where you'll see often quoted in the literature that by 2050, antimicrobial resistance may kill more people than cancer, and that's where this came from, the modeling that this group did. They also were some of the first to really look at the issue of economic incentives and the need for those to sustain the health of the antibiotic pipeline. And again, I'll talk more about that in a later slide. Next slide. The WHO, of course, is very concerned about antimicrobial resistance and has really beefed up their efforts focused on this topic over the past 5 years or so, starting in 2015 with the release of the Global Action Plan on Antimicrobial Resistance. And this really is a call for all the member states to consider the diverse aspects of antimicrobial resistance and to establish their own national action plans to attack this problem on multiple fronts. In 2017, WHO released a priority pathogens list for research and development of new antibiotics. And at the top of their list in the critical position are these 3 gram-negative bacilli that I will mention in my second presentation. They also have more recently released a clinical and a preclinical pipeline tracker. And so if you go to their website, there are quite a few different data visualizations for the clinical and preclinical pipelines. To my knowledge, the preclinical pipeline is sort of on a voluntary basis, so I'm not sure exactly how complete it is, but it at least gives you some sense for the types of products that are out there and under development. And finally, just earlier this year, WHO released a target product profile report for needed antibacterial agents for some of their top priorities globally, which include enteric fever, gonorrhea, neonatal sepsis, and urinary tract infections. Next slide, please. So then on the animal side, and forgive me, I'm not as well versed in all of these organizations and acronyms, but hopefully if you have questions about any of this, my USDA colleagues can chime in. The FAO and the OIE, Food Animal Agriculture Organization, and the World Organization for Animal Health work together along with the WHO. They're sometimes referred to as the tripartite, to look globally at antibiotics in animal agriculture. In 2018, the OIE released a list of antimicrobial agents of veterinary importance. You'll see down at the bottom of the slide, the FAO and WHO together via Codex Alimentarius released guidelines for risk analysis of foodborne antimicrobial resistance. And then over on the right-hand side, the FAO released a report in 2016 on drivers, dynamics, and epidemiology of antimicrobial resistance in animal production. Next slide, please. So in 2016, there was a high-level UN General Assembly meeting that focused on antimicrobial resistance. So this was a really big deal. I think it was one of a handful of times that a health topic had been addressed in that type of forum. And what came out of that meeting was the establishment of an interagency coordination group, or IACG, on antimicrobial resistance that worked over the next several years to produce this report that you see on the screen, No Time to Wait, Securing a Future from Drug-Resistant Infections, that includes a number of different recommendations in accelerating progress in countries, innovating to secure the future, collaborating for more effective action, investing for a sustainable response, and strengthening accountability and global governance, all linked to the UN Sustainable Development Goals. Next slide, please. So in parallel to this, there have been a number of different international global funding bodies and funding coordination groups that have sprung up to foster research and development on this topic, as well as to coordinate who is doing what. So what I'm showing on this slide is the Innovative Medicines Initiative program, specifically the New Drugs for Bad Bugs, ND4BB, which has a number of different work packages to address antimicrobial resistance. This was a very large, very well-funded effort that is, some of these projects are still ongoing, including a large clinical trials network that is conducting clinical stage development of some key products. The JPI-AMR has been around for quite a few years now as well. Again, it began in Europe, but a number of countries from around the globe have now joined. And this group issues joint funding calls focused on a wide array of topics of relevance to antimicrobial resistance, not just on the human health side. They've actually had calls for resistance in the environment and other types of research questions. GARD-P was a program that was spurred by WHO and modeled after the Drugs for Neglected Diseases initiative. So this is a global nonprofit that is focused on developing key antimicrobials for the global health community. I'm going to mention them in my talk as well, because they're now one of the partners to whom NIH hands off some of the drugs that we help develop. And then finally, down at the bottom, when Germany had the chair of the G20, the global group of 20, they focused on antimicrobial resistance. And one of the key things that came out of their chairing of that group was the establishment of what is now called a global AMR research and development hub. And so this is a global group that has country representation as well as some of the large funders that sit on it, like the Wellcome Trust, Bill and Melinda Gates Foundation, etc. They've done a few things so far. They have a dynamic dashboard that pulls in research project funding from different funders around the world. They have a pipeline gallery as well. I actually just learned about this morning. They are sort of taking both the Pew analysis and the WHO analysis and sort of blending it together. They also have recently launched an incentives gallery. So they, I guess, are going to be doing some work on the antibiotic incentives question, which leads me to my next slide, please. So economic incentives for drug development. So what has become clear and what is kind of the elephant in the room in a lot of meetings that I attend on antimicrobial resistance is that there is market failure on antibiotics. There have been a number of cases now of small companies who have successfully developed antibiotic products, gotten them approved by the FDA, and have then declared bankruptcy, or have had to close down their research and development unit, or have had to, or have been acquired by other companies, and then those products have been put on the shelf. And this is really concerning because the US government and other funders have put a lot of money into the development of these antibiotics, and and with uncertainty about their availability to come. And so one of the things that many groups have now focused on, starting with the UK AMR review, is the need for what are referred to as pull incentives. So you can think of these as carrots that entice companies to develop antibiotics, providing a source of revenue for them when the market doesn't provide that, because we want to hold new antibiotics in reserve, use good stewardship, and etc. So the UK AMR review, as I mentioned, as well as others, have converged on a policy solution called a market entry reward, which would delink antibiotic sales from use. Many groups have sort of settled on a price tag for this of about $1 billion per drug, which for obvious reasons, no one is rushing to implement. Some other ideas that are out there, including from the Duke Margolis Center, are enhanced reimbursement through unbundling payment for inpatient drugs from diagnosis-related groups. That's how inpatient care is reimbursed in the United States, and the idea is to reimburse these drugs separately so that there's no disincentive to using them. Or others have called for the use of a subscription model where a group such as a government might pay for a set number of courses of a new antibiotic, and the UK is piloting such a subscription model. So colleagues in CMS and BARDA have taken some steps to try and address this, and I do think it is a major topic in this field, and one that you will probably hear a lot about as you go about your work. So next slide. So with that, I'm just going to put up the bullets that I believe you've already seen, because these were submitted as part of the scope and charge for this group. These were solicited from across the interagency, again, for opportunities to add value of what has already been done in this group. And this first slide is the sort of more human health side, and then the next slide is opportunities on the animal health side. So with that, I'm going to stop, and hopefully we can have a good Q&A session along with some of my colleagues from other agencies.
Thank you, Jane. And I just wanted to, sorry, I just want to remind people, if you could use the raise hand feature, and then Guy can call on you in the order that the hands go up. Also, we don't have to finish all the questions for Jane and others in the next 20 minutes, because we do have further time set aside on tomorrow's agenda. So, yes, okay. Lefteris, I think.
Yes, thank you. Thank you very much for this presentation. I would like to help me clarify the terms, how you understand the terms antibiotic, antibacterial, and antimicrobial, because those have been used throughout the presentation. Is our goal only antibacterials? Is our goal broader than that? And what is the expectation? I have two more follow-up questions. I can ask them now or next.
Yeah, that's a great question. So antibiotic and antibacterial, we kind of use interchangeably. So antibiotic has sort of a specific meaning. It's like a natural product that has an activity against a microbe. So the more technical term, I think, is antibacterial, but I think what's familiar to a lay audience is antibiotic. And so that's what we used in the CARB documents, et cetera. But then other places we use antibacterial. So I consider those to be interchangeable. And then antimicrobial would encompass those, but would also encompass drugs that have activity against other kinds of microbes. I think the authorizing language here used the term Let me just check on the first slide. AMR, antimicrobial resistance. So with that, I think it is kind of up to the committee. I will tell you that CARB recently decided, and the CDC threat report recently elevated a fungus, Candida auris, to its urgent threat level. And the CARB made one of its recommendations in its most recent report was to intensify attention on antifungal drug development. But I think there is a little bit of latitude there. And I don't know if anybody else wants to weigh in, Michael or others.
This is Michael. I would echo what you said. I would just say generally from the CDC perspective, the biggest issue for us in terms of messaging to the public is often their familiarity with the words. And we have found, and I think the Wellcome Trust actually did a review of communications to the public as well, and found that people understood antibiotic and they understood drug resistance. There's a significant drop when words like antibacterial and antimicrobial were used. So we generally use antibiotic even when we're talking about all of the threats that are highlighted in our threats report, which do include bacteria and fungi. So it can be complicated. I would also just note that's sort of the US experience, although that Wellcome Trust survey, I think, went beyond and covered parts of Europe as well. I think globally, AMR is the much more common term of art, but we have really stuck to AR given that we want to make sure the public is understanding and all the materials as accessible as possible.
Thank you.
Could I ask my follow-up also? I would like to, if you could go us through in bird's eye view of the step-by-step how you coordinate transition of development from one stage to the next. Is there an overall approach that NIAID and NIAID are using in order to help facilitate those handoffs? And also you mentioned about the incentivization of antibiotic use, and I don't know if fidaxomicin you would consider a successful example of this or not. Thank you.
What was the drug you said? I'm sorry.
Oh, the C. diff, the fidaxomicin that was incentivized. It was the first incentivized example, a few years back.
Fidaxomicin for
CDI.
C. diff?
Yeah.
Yeah, I don't know a ton about that particular drug, sorry.
Right, thank you.
I mean, I know of it, but I don't know the history of its development. I would say for handoff, we work very closely with BARDA as well as DOD. There's a part within, office within our division that focuses on later stage development. And they meet very frequently with colleagues at BARDA to discuss the progress of candidates within the portfolios. Another way that we interact is through CARB-X, which we haven't gotten to yet, but that is a global public-private partnership to support antibiotic development. Actually, it's also diagnostics and vaccines. And NIAID is a member of the Joint Oversight Committee and also participates a lot. BARDA is the primary funder, although a lot of other funders have also joined in there. I don't know, Mark, do you have anything to add to that?
Yeah, thank you for that introduction, Jane. Yeah, the CARB-X program, as well as both the Advanced Research and Development Program, we definitely reach out to not only NIAID to talk to them about what they're seeing within their development programs, but we also talk to our partners at the DoD as well as other partners internationally, just to understand the full scope of the development pipeline. The reality is that many of these programs are coming up through the pipeline from various agencies, other funders. So to understand what's going on in the total landscape is key. But in my presentation, I will touch on the handoff, if you will, from NIAID to BARDA. It's definitely a great way for us to have an insight into what is going on with the program. And really the key goal is to de-risk the program as much as possible so that we can see success and a product approval at the end.
Yeah, and I'll just add, so I'll give you one example of a handoff to both BARDA and GARD-P in my second talk. But another one that I didn't have room for, I'll just mention it here, is zoliflodacin, which is not yet approved. It's in a phase 3 trial right now, a global phase 3 trial. It's a single dose oral antibiotic for Neisseria gonorrhea. And that was NIAID supported extensive phase 1 trials for that drug. I think 2 or 3 different phase 1 trials. And we really have been in active partnership. We supported the phase 2 as well. And we've been in active partnership discussing with GARD-P the strategy for the pivotal phase 3 trial, helping with site selection and things of that nature. So we definitely know the folks at GARD-P as well as BARDA and have those relationships to assist us when we want to transition a product.
Yes, this is Guy Palmer. Dr. Strigachis has a question about scope, which I think probably is on the minds of multiple committee members. Go ahead, Andy. You may have disappeared. Andy, do you want to ask that? Go ahead and proceed with that. All right. Don't know if we temporarily lost Andy, but we'll move on to another question. So one of the questions we have had about scope is which you've addressed a little bit of, with a focus on bacteria and perhaps some fungi as well, such as Candida auris, but also the specific case of tuberculosis. And, you know, it's sometimes treated separately, it's sometimes treated as part of this. And so your kind of viewpoint on that.
Yeah, and I'll invite, again, my colleagues to weigh in. So TB and multi-drug TB is clearly a huge public health challenge and threat globally. And, you know, it's certainly a major priority for NIAID. I think the reason why it tends to be handled separately is because it's sort of a different set of challenges to address, have an effective tuberculosis control and treatment program. And so actually the first CARB National Action Plan, there was a separate TB National Action Plan, just because the issues are so different and involve international considerations. You know, the fundamentals are the same, but the specifics are different. And so just as one example, in my division, the mycobacteria are actually housed in their own section in a different branch. So of course we interact, but it's a different group of people who kind of think about and deal with the mycobacteria compared to sort of the regular hospital acquired bacteria that at least my group thinks about more. So I'd welcome if anyone else wants to weigh in on TB.
Hi, yes, this is Jessica Petrillo from the USAID. And I just wanted to mention that when we originally developed the CARB national strategy, the intention was to elevate, a subset of high priority pathogens that were not getting what was felt as, the level of attention that was needed. And that while there were, it acknowledged from the beginning that there were existing programs such as TB, malaria, and HIV that were addressing the issue of AMR. And so the scope of the original national strategy was very narrowly focused for sort of the US, priority threats, bacterial ones that were felt to have not been elevated to the level of attention that were needed to really address the threats. And so I think that as the committee is navigating its charge, these are going to be things that need to be taken into consideration, because the appropriations text both says, the CARB refers to the CARB as well as the threat of antimicrobial resistance. And so it'll just be one of those important things to keep in mind, that there was an intention of narrowing the scope of the CARB national strategy to tackle a certain element of sort of the broader AMR threat to, the United States and US interests at home and abroad, but it did not in any way intend to negate those other areas that were being tackled by other lines of effort. So again, the appropriations text touches on both this sort of narrower scope and this broader scope. And I think it'll be one of those elements that as the committee and working with NIH and Jay Nisley in terms of, where is the most value add that this committee can really contribute to the issue within sort of the mandate that it's been given. Thank you.
Thank you. That's helpful. I think obviously our committee is just beginning to meet. I think there is probably an understanding to treat TB separately from this issue, but we're exploring that, and any feedback from any of the agency representatives I think will be helpful as we really define the scope of the agents, the pathogens that we're going to be addressing. Two things. Andy Stragachis has a question. Well, apparently we've put him on permanent mute, which is, so one, if we could get some tech support to see if we can get Andy to unmute would be good. But his question is, has to do with the first statement of task, which is quantify the long-term medical and economic impacts of AMR in the US. And his question is, are we to interpret this as commenting on estimates, as an example, the CDC threat report, as opposed to the complexities of generating another estimate on the medical and economic impact of AMR?
Thank you for the question. It's a great question. And while I wish I had insight into what the intent was when this language was drafted, I really don't. So I will toss that question and see if Michael Craig or Amanda want to make any comments on this question.
Thanks, Jane. This is Michael Craig from CDC. I would say that when I read that response, I don't think that it covers the scope of commenting on specifically the surveillance or the counting in the threats report. When it says the medical and economic impact, to me, that goes into some of the pieces that we are very interested at CDC that some folks have released, but that I don't think have been well quantified. And that's going into, antibiotic resistance is not just the threat of infection and the morbidity and mortality numbers, but it ultimately comes down to complicating medical treatment, complicating cancer therapy, maybe delaying it in some cases, transplant surgery. All of those issues of prevention and sort of the modern medicine aspects how is that complicated by antibiotic resistance? How do we quantify that in a way that is even above and beyond sort of the infectious pieces, the death pieces? And I think likewise, what does that look like, you know, varying in the developed world? What does it look like in LMICs? And what is sort of the projection of it? And you know, do we have a timeline where, you know, maybe we are okay for some of these things with the resistance levels kept at a certain place, but if they get to, you know, magnitudes from where they are, if the resistance accelerates in any way, where are sort of our tipping points or our precipices? And likewise, what is sort of the economic impact of that? I think there has been some modeling globally that Jane referred to, that the UK group did, supported by the Wellcome Trust. I think that was the sort of big picture numbers. I don't know that we have gotten to the point where we have high quality specific data on some of the economic impacts country by country. And I think those are some of the pieces where, when I understand the question and based upon sort of our work on the threats report, I think that's probably the biggest need and the biggest gap left to be identified.
Okay, thank you, Michael. So what I maybe interpret from that is that one of the goals of the committee would be to look at the breadth of the economic estimates done to date and determine if those are fully inclusive of the costs and also costs of risk avoidance and, you know, delaying surgeries, not undergoing a certain kind of therapy, et cetera. But to look at those economic analyses to date and examine those for gaps with recommendations to how to improve those for the future. Would that sound, am I repeating what you, am I summarizing what you laid out?
Yeah, I think that's right. I mean, I think there is certainly a lot of complexity to it. I mean, I think one could draw a parallel to what we're experiencing with the pandemic right now. There is the absolute numbers in terms of morbidity and mortality. And I don't think the question as I read it or the statement that you guys are exploring are really getting into, you know, delving into that and coming up with, well, is this the right methodology or not? I think it's more what is behind those numbers and what is the implications, what is the impact on the economy, what is the impact on the medical care system, both in developed countries and lesser developed countries, and what are those impacts that have both sort of human and economic impacts that go well beyond the number of cases and the number of deaths, of which, you know, for the pandemic, I think we're sort of living it, experiencing, reading about it every day. But I think for antibiotic resistance, it has not been quantified or described in the level of detail or need that we really all need.
Sure. Okay. Thank you, Michael.
And with that, sorry, just one additional, this is Jessica Petrillo again from USAID, is also the, there's elements in terms of, again, we have the lost earning power, so lost days from extended, you know, illnesses, but also potentially the socioeconomic in terms of removing women and children from the workforce. And so, you know, really looking at, you know, what the you know, potentially second order costs as well.
Thank you, Jessica. That's helpful. All right. If there's, this is not our last chance to ask questions. So Jillian, I think we're about at time to move on to our second speaker.
Yeah, I think this is great, and we can revisit if there are any clarifying points later today and tomorrow. So is Amanda Cash? I'm looking for Amanda.
Yeah.
I see you. Okay. Looks like we're all set. Amanda is a director at the Division of Evidence Evaluation and Data Policy in the Office of the Assistant Secretary for Planning and Evaluation at HHS. Go ahead, Amanda.
Okay. Are you putting my slides up or? You're muted, Jillian.
Sorry, I was saying that I could, or you could. It doesn't matter. I will pull those up. Here we go.
In the meantime,
Great,
I think
you.
I'm back now, Guy.
It's good to have you back, Andy.
Yeah, I was using an older link, apparently, that was sent to me. So I'll mute again. Thank you.
It was nothing personal. So.
Okay. While Jillian gets those started, I just want to say good afternoon and thank you for inviting me to present today. I'm going to go over the evolution of our previous CARB National Action Plan and where we are today with the new plan. And I'd like to say up front that if you take anything away from this presentation, it's that the U.S. government is committed to continuing the fight against antibiotic resistance. And the reason we say that, or I say that, is because the current National Action Plan technically ended in the spring of this year. So that's why we actually are here today with a new plan. So if you want to go to the next slide, Jillian, or do you want, I think, should I?
Can other people see it?
Yeah.
Okay.
It's just in it's not in a presentation mode. It's the.
Oh gosh, it is on my screen. I don't know why. On my screen.
You might have to click enable editing.
Yeah.
1 second. Oh, okay. Is that better?
We can't see them anymore. I can.
How's that?
Oh. Almost there.
Is that better?
Yes.
Perfect.
Yes. Okay. So there we go. So I'm going to go over these first few slides fairly quickly because I think most people are familiar with the issue. That said, I'd like to state that in addition to broader public health advances, antibiotics have contributed to historic improvements in overall health, and we now know that we can't take these advances for granted because microbial pathogens continually evolve in new ways to evade the drugs designed to kill them. And as our Assistant Secretary for Health recently said, evolving microbes are a battle we just can't win. Antibiotic resistance threatens our ability to treat and prevent infections, as Michael just kind of discussed, and Jane. And we now know that more than 2.8 million illnesses and 35,000 deaths result from resistant infections each year in the US, and that the healthcare costs are commensurately extreme. Next slide. So some of you may know that the US government is responding to antibiotic resistance with a comprehensive and coordinated suite of actions implemented by a diverse set of agencies using a One Health approach. While federal efforts to address resistant infections go back decades, the current form of the response was instigated largely by the 2013 CDC report on antibiotic resistant threats to the US. And as you know, we now have an updated report. And in 2014, an executive order and simultaneous national strategy for combating antibiotic-resistant bacteria, what we affectionately called CARB, brought the US government effort together under one umbrella with structure and strategy to guide our efforts. The CARB Task Force and the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria were also established at that time in that same executive order. And in 2015, the CARB Task Force translated that national strategy into a concrete 5-year national action plan. And the task force includes US government agencies that oversee human, animal, and environmental health and promotes collaboration and coordination across the US government. Next slide. So the national strategy for CARB is the foundational document that guides the work of the US government, and it's organized around these 5 goals. The shorthand language we use for these goals is infection prevention and stewardship, surveillance, diagnostics, treatments, and those same components are focused globally in the last goal. The U.S. government effort also takes a One Health approach, which recognizes the interconnectedness of the health and of people, animals, plants, and the environment. The CARB task force pulls together the relevant agencies across the One Health spectrum to promote collaboration and communication again. And, you know, I just want to say that the national strategy from 2015 was an incredibly dense document. If you've ever looked at that that plan, there's a lot in there, and so we've worked to actually pare that down a bit. So next slide. You'll see that these are the agencies represented on the CARB task force, which is co-chaired by the Departments of Defense, Health, and Agriculture. The Office of the Assistant Secretary for Planning and Evaluation, or ASPE, my office, within the Office of the Assistant Secretary of HHS, serves as the federal coordinator for the task force. As I mentioned previously, and as Jane alluded to in her slides, the Presidential Advisory Council on CARB, or the PAC-CARB, is coordinated by the Office of the Assistant Secretary for Health, or OASH, which is the sister division within the Office of the Secretary. Just to be really clear, a lot of people get very confused on what's the difference between the Federal CARB Task Force and the PAC-CARB. The Federal CARB Task Force, the reason why we call it the Federal CARB Task Force is because it's only feds. It's, you know, you see the agencies listed here. There are no outside entities that are part of this task force. It is purely internal coordination and collaboration. The PAC-CARB, the Presidential Council, is a federal advisory council that is designated to give advice to the Secretary of Health and Human Services. So it's all external experts and SMEs that give advice to the federal government through the Secretary. And so, as Jane mentioned in her talk, that you know, there are ex officio members that are feds that are on the PAC-CARB, and we work very closely together with the PAC-CARB and the office that coordinates it. But I just want to note that there's sort of external and internal, and for us, internal is the Federal CARB Task Force, and external is the PAC-CARB. Okay, next slide. So what have we done since 2015? We've made a tremendous amount of progress, and since the first National Action Plan was launched. And you can see here just a few highlights. The U.S. government worked with partners on all of these achievements, including the AR Lab Network, CARBX, the accelerator that Jane mentioned that I suspect Mark will talk more about, and the 2018 AMR Challenge, just to highlight a few. The task force has reported on these advances each year as required by the executive order, and we'll be publishing a comprehensive summary of progress for our last year, and that should be up later this afternoon. We have a lot of organizing to do and information to put into that report. If you'd like to look at our previous annual reports, those are posted on the ASPE website, and you can just Google CARB year 1, year 2, year 3, year 4 annual reports, and they'll pop right up for you. Next slide. So it's important to note that the health metrics we track are influenced by a variety of interdependent factors, making it quite difficult, if not impossible, to establish single cause and effect relationships between specific activities and specific outcomes. But we're seeing progress. In recent years, overall deaths from resistant infections have fallen, and specifically deaths from resistant infections in hospitals have significantly decreased. We know that more U.S. hospitals are implementing high-quality antibiotic stewardship programs, and as many of you also know, these programs are resource and time-intensive for hospitals, and major efforts have been made by a variety of federal agencies to support hospitals in these efforts. So I just want to note that, you know, what this graph demonstrates is no small thing. Next slide. So I also want to note here that while we've made a lot of progress, there are still too many resistant infections. There are still too many deaths from resistant infections. We also know that new resistant pathogens will emerge, Candida auris was not included in the 2013 CDC threats report, but is now considered a serious threat, as Jane also mentioned previously. CDC's reported that some resistant infections, particularly those acquired in communities as opposed to hospitals, are increasing, which is, alarming to say the least. There are also significant ongoing challenges to developing new antibiotic products, an issue that many parts of the task force are currently addressing, and that we hope you as a committee will also examine. And Jane went into much more detail about that as well. Next slide. So knowing that 2020 was not the end of the story and that the first National Action Plan was a foundation to build upon, in the fall of 2018, we pulled together many federal experts to contribute to this process, crossing the One Health spectrum. We reviewed our efforts thus far. Several ongoing efforts were happening at the same time that we sort of tried to pull from to ensure that we were not duplicating. And thus far, what was coming into the future, we wanted to try to understand as much as we could. And then we asked the CARB, the public or external entity, to actually solicit public input. And they did that. And the public, you can see from this graphic that these are the things that the CARB told us based on their own expertise and what the public told them that we should address in the new National Action Plan, which we have done. Next slide. So the resulting CARB National Action Plan for 2020 to 2025 presents a set of coordinated strategic actions to change the trajectory of antibiotic resistance in the next 5 years. The new plan maintains the original 5 goals as set by the national strategy and adds new objectives and targets. Some of these targets reflect multiple agencies' activities. We've also described potential challenges to implementation that we can anticipate at this point. We were told that we really needed to be more transparent about our challenges and measuring them. It's important to note that some of the objectives in the new plan build on existing programs and policies, while other objectives reflect new activities. Implementing all of the activities outlined in this new plan that's coming soon will depend upon availability of resources as well as capacity. We always have to say that in the federal government. Because we never know what's going to happen year to year with our budget. So the new National Action Plan also continues to reflect a One Health approach and prioritize infection prevention and control, the appropriate use of antibiotics, and support for innovative new products. Our work since 2015 has clarified the task force's understanding of the challenges inherent in collecting and analyzing data. So the new plan continues and enhances the focus on collecting data and turning it into useful information. We've also developed an updated measurement and reporting strategy, setting quantitative targets wherever possible. We'll be updating those targets in our annual reports as needed, so we're taking a more flexible approach in that regard. You'll see in the new plan that it's more streamlined with a new, with a more comprehensive approach to measuring our outcomes. But please note that the new plan, as with the old plan, is in no way reflective of the complete breadth and depth of the U.S. government's portfolio on antimicrobial resistance. Next slide. We know that we can count on this audience to stay engaged. Unfortunately, our plan has been delayed a bit for going public. So we're expecting a new targeted publication for early October. Watch for the annual reports on progress under this new plan. Those reports will reflect everything that's in the plan and sometimes more. And we'll also be publishing a report, as I mentioned before, covering the final year and the overall summary of progress under the original 5-year plan. Yeah, and I think with that, I will end and take any questions.
Okay, do we have any questions? Cesar, I couldn't see if your hand was up or just was up accidentally, so.
Accidentally.
Oh, okay. Any questions for Amanda? Joanne?
Yeah, I have a question. Someone was asking if we could get an advance copy of the 2020 to 2025 plan, if that's possible.
Unfortunately, no, since we're so close to publication, we are happy to send the plan out as soon as it's published. We're hoping sometime next week or the week after, so we'll be delighted to share it.
Looks like Lefteris has a question.
What would you say is the biggest challenge that you have faced so far?
Sorry, the biggest?
Challenge.
Oh, I would say right now it's incentivizing the market, fixing the broken antibiotic market, if you will.
Can you elaborate a little? How do you perceive that, and any thoughts that you have? Thank you.
Well, sure. I mean, I think that we have different pots of funding that address different parts of the pipeline, but we are still struggling with what suite of interventions will do to help advance the market and ensure a more stable market for developing drugs. You know, I think Jane talked a little bit about this in her presentation, and I'm sure we'll get more into this in the next few meetings, but this is a problem globally, not just domestically, but you know, as my colleague, I think Lynn Silpe is on, has mentioned many times, the rest of the world is sort of waiting to see what the US is going to do in terms of incentivizing the drug market. And we still are figuring that out because it is a very complicated issue. We have a work group at HHS that has been developing policy recommendations for the last year and change. And, you know, we've uncovered a lot of information, but we still aren't quite there yet in terms of understanding exactly all of the things that need to happen to fix the market, if you will. You know, I don't know if Mark or Jane, you want to, or Lynn, if you, or Michael, if any of you want to add anything to that.
Yeah, this is Mark Albrecht. I can just add that around the world, there are several different levers that we have available to us to advance early stage product development, middle stage product development, and advanced development. It's once a product gets to that post-approval product launch phase that there really is an absence of funding and support. The challenge suddenly becomes a company has received all this funding for product development. They're now no longer getting that capital and trying to manufacture a product to then sell, while at the same time funding the development of the sales force to sell the product. So it all of a sudden becomes a huge resource intensive period where they're spending money to make product to sell, standing up a sales force, and then trying to then make a revenue at the same time. And it really becomes an enormous challenge. It's really at that time that we need additional levers, if you will, to pull to really support that initial phase. Originally, people were talking about the valley of death being the post-IND phase. With BARDA, we've definitely pushed that into an earlier stage of development, and pushed it down into preclinical. I think that with NIAID and CARB, as we've discussed earlier, that space has now been mostly resolved, and we've really pushed the valley of death all the way out to post-approval, and it's trying to come up with that new mechanism to resolve that. And I really think that the efforts of this economic incentives working group that has been stood up has really posed some good ideas. I think that there's opportunities to explore new policies moving forward and really resolve this in the end.
So Amanda, let me just, go ahead. I'll have a follow-up question to that.
Sure. I'll just add to what Mark said is the reason why it's so hard, one of many reasons is that you still have competing generic prices and Medicare reimburses at a lower rate. And so you have, old drugs that still work, and you also don't have clinical guidelines that are updated in a timely way and that sort of often, not always, but can impact formularies and what's reimbursed and at what rate. And so there is a complex confluence of issues that make this an incredibly intractable and very difficult problem to come up with a solution. And I very much believe that there's not one solution, that we need to do many things to try to fix the market, if you will, or stabilize the market for developing new drugs. And we're trying.
I believe you are trying. My question was, you were mainly talking about new antibiotics or bacterial targeted therapeutics. How about diagnostics on the other side, point of care diagnostics that would allow a clinician to make a much more rapid and informed decision?
Yeah, so I mean, that's a great question. And you can't see because the slides are gone, but one of the reasons why we have the goals split into 5 goals is we have one that's therapeutics and vaccines, and the other one is specific to diagnostics. And we split those goals in 2015, and we continue to maintain the split to put more of a focus and a spotlight on diagnostics. They are still very necessary. I think innovations are happening, and I'm really interested to understand how COVID will impact the development of new diagnostics. But it's still an issue, and I'm happy to have my colleagues chime in on this issue.
So I'll mention something, this is Jane, I'll mention something in my next talk about a prize competition that NIH and BARDA recently completed for a novel diagnostic. We too view it as a really crucial issue that's sort of at the center of a lot of things of antimicrobial resistance. You can't have good stewardship without good diagnostics. It's really difficult to enroll some of the clinical trials without rapid diagnostics. And there are technologies that are, new technologies that are out there and products approved. There are a lot of others in concept development. And it's really important to keep pushing on that because it is such a critical issue.
Okay, yeah, we'll look forward to that part of your presentation, and also possibly to discuss incentives for clinician use of those point of care diagnostics or behavioral adaptations to encourage their use, both economic and behavioral incentives for that.
And I just would add it, I agree with all my colleagues here. I think the overriding challenge and one of the themes that you can hear is that there's been tremendous progress. But as much as we have made progress, we just uncover the greater and greater complexity of antibiotic resistance as an issue. The incentives are a challenging issue. The stewardship is a challenging issue. The complexity of it as a One Health issue is an issue. And I think one of the overriding themes across all of this, in terms of the obstacle question at hand, whether you're dealing with the diagnostic pieces or whether you're dealing with the incentives, is ultimately the resource allocation. And what is the resource allocation for this issue writ large? I think we have had some new resources and some new influx of resources. And as I said, we've made progress, but even with the progress, we feel like we're still falling behind, and we still feel like we have not in any way gotten to a point, even in the US, where we are in a good place, let alone globally. And so I think ultimately, I think that's a good thing to keep in mind, is what is the resource allocation for this topic writ large? How does it compare to other global health issues? And what are ways that we can bring more resources to bear? And I think that that's true on the development side that's been talked about. It's also true on the prevention and public health side, the data, the vaccine development, all the different pieces that are in the CARB action plan, and all those different goals that we face.
So actually, I have a question that tees up very, very well. You're talking about the progress that's been made. I was wondering, Amanda, I know you said that it's been difficult to assess causality, but could you say more about how you were trying to assess, which actions, if any, are responsible for the drop in mortality from resistant infections? It seems like if we're asking about resource allocation, that's sort of the first thing we should really figure out what's working.
Yeah, I mean, I think we know stewardship works, and we know that we need to keep pushing on implementing stewardship programs. I think that, we don't have a way to do a natural experiment necessarily to determine causality, but we can see pretty easily after 2015 an incredible, I guess what's the word I'm looking for, effort and spotlight on CARB. We saw a lot of new money coming to the federal government to work on antibiotic resistance, and expanded portfolios in different parts of the government, especially for us in HHS. I think there are still gains to be made on the animal side, and I'm sure that Nina would be happy to talk about that. But there's been, I don't want to say, how we've measured something in a rigorous way, because often we don't have the luxury of doing, randomized controlled interventions or evaluations of our programs. But it passes the smell test that after the executive order and the national strategy and action plan, and then, a lot of an explosion almost of resources and attention on the issue. And I don't know if my colleagues want to add to this, but I do think we are trying very, I'll say, since we started developing the new National Action Plan, it has been a struggle. And a lot of us have, and we have driven a lot of the people who helped develop and did develop the new National Action Plan to put stronger measures in place to understand and target sort of, this is where we are now, this is where we are a year later, and this is how we need to change this target, or this is how we need to adjust where we are because of resources, capacity, whatever the case. But I think going forward, we do have a better way to measure our progress than what we've done in the past. But I don't know if anybody else wants to add anything to that.
Michael, you're muted.
You're muted, Michael.
Sorry, I have a double mute here. Would echo everything that Amanda said and magnify that. I think one of the key areas where I would say that we have had success, although I would again echo what Amanda said, that it's hard to do sort of the randomized, controlled way of leading us to authoritatively say that it was because of these discrete things, is on the healthcare side, and particularly what we have seen in terms of prevention of healthcare-associated infections and those resistant infections in healthcare over the past few years has been a tremendous success. And that one we can point to a lot of investments, a lot of policy actions at the state and federal level that have been put in place over the last few years that we think have contributed very significantly to that progress that we've made and what we have seen there. And I will say, for the resources that Amanda alluded to that have sort of come after that, those were the areas where we saw the most deadly infections, the highest number of infections, and where we invested a lot of resources. And I would just note, we had a lot of good interventions at the ready to scale up. On the other side of the coin, as was alluded to, the community side of infections, where we see infections coming in the communities, where we see ESBLs and other types of infections, these drug-resistant urinary tract infections, we don't have the same understanding. We don't have the same interventions. When you're dealing with anything, when it's with community spread, the complexity is a lot more challenging than when you're dealing in a contained healthcare environment. And so we have seen, relatedly, ongoing increases, and in fact, for some pathogens, very high increases in both the overall burden of those community-resistant infections and some of those specific rates of resistance. So I think those are some, more specific areas of investment and challenge that we face. But I think I would say on the resource side, the dollars can make a big difference, and the resource allocation is, I think, fundamentally one of the biggest things that we deal with and that challenge us from a federal government perspective.
Okay, I think we're going to take advantage of a little break in the action there to move on to our next speaker.
So I saw Nina Anandaraman from USDA. Nina, do you want me to advance your slides or do you want to do it?
Looks like she has started. She's
Okay.
Apologies, I was on mute. Yes, I think I can share them. Thanks. So thanks so much for the opportunity to be able to share with y'all today the work that USDA does on antimicrobial resistance. So first I'm going to give you an overview of the USDA agencies and offices that work on AMR. And then I'm going to give you a really broad overview of the USDA AMR Action Plan, which forms the basis of our work on CARB. And then finally, I'm going to introduce you to our USDA Science Blueprint, which sets a vision for our science priorities for the next 5 years. Sorry. So we have 10 agencies and offices across USDA that work on AMR to some extent, and 3 of those are on the CARB task force. The first one, the Animal and Plant Health Inspection Service, as an animal health mission, and the third one, the Agricultural Research Service, has an intramural research mission, and then the 5th one, the Food Safety Inspection Service, as a food safety mission. So those are the 3 that are on the CARB task force and have the most inputs into CARB, and we have some agency reps here on the line as well to help answer questions if they arise. And the other agencies that also work on AMR to some extent, we have the Agricultural Marketing Service that's responsible for third-party verification of label claims. The 4th one there, the Economic Research Service, that evaluates economic impacts. Then the 6th one is the Foreign Agriculture Service that facilitates our international engagements. And then the 7th, the National Agricultural Statistics Service, that conducts surveys along with APHIS on farm. And then 8th, the National Institute of Food and Agriculture, NIFA, is responsible for extramural research and also has inputs into the plan. And then the 9th one, the Office of Pest Management Policy, works with other agencies on pesticide issues. And then finally, the office I'm in, the Office of Chief Scientist, coordinates across USDA, and we serve as co-chair on behalf of USDA on the task force. So this infographic is from our USDA AMR website, and it's here mainly to show you that there's various plausible pathways for resistance transmission. And there's been many like this. Back in the 70s, you had a diagram often referred to as the confusogram, and put out by Linton. And there's been many iterations of that confusogram since. And it's called that, of course, because it has these various sectors. It's got the farm environment, it's got human healthcare settings, it's got waterways, wildlife, crops, companion animals, and it's got arrows going from every sector to every other sector. Hence showing, that the ecology of pathogen flow is complex, and it's really, we need a variety of experts and technologies in these various settings, really to provide context and information to help answer questions. And that just really resides in so many different sectors, and that's really what that's conveying. And so right now, our understanding of the factors that contribute to development of infectious disease in various sectors is still very incomplete. And the ability of these microorganisms to move around these sectors and over large distances and through different populations, people and animals, makes it really challenging to know with certainty where different strains originate. And why is this important? Because these knowledge gaps then impact our ability to really prevent dissemination and spread and understanding development. And so in order to identify and implement effective mitigation strategies, we need all of these different sectors working together. And our plan, most of our plan is dependent on voluntary participation, which adds more complexity. And so, of course, how to look at this, is the One Health paradigm that was just mentioned, the interrelatedness between the human, animal, environmental health, and that's what the CARB plan is based on. So the USDA AMR Action Plan was published in 2014, much in concert with the national strategy. And the way that was developed was we held a workshop with our external stakeholders as well as our federal partners, and we got extensive feedback on the gaps that are in these three objectives here. The first one, determining and or modeling patterns, purposes, and impacts of antibiotic use in food-producing animals. The second being monitor antibiotic drug susceptibilities of selected bacterial organisms in food-producing animals, production environments, and meat and poultry. And then the third, identify feasible management practices, alternatives to antibiotic use, and other mitigations to reduce AMR associated with food-producing animals in their production environments. So our overall goal is to generate and disseminate science-based information to veterinarians and our ag stakeholders to help them to mitigate AMR and then therefore increase the lifespan of the use of these antibiotics. So the vision for the plan is mainly around the interdependence of the research, surveillance, education, outreach components, and very much like the One Health, human, animal, and environmental interdependence. And surveillance really is the cornerstone for the other two. So surveillance and monitoring, we conduct, to gather data. So for example, with the National Antimicrobial Resistance Monitoring System, or NARMS, we're working with FDA and CDC to collect AMR data. Our APHIS agency is working on the National Animal Health Monitoring System to collect antimicrobial use and resistance data. We're collecting animal diagnostic isolates through the National Veterinary Services Laboratory, as well as the National Animal Health Laboratory Network. So we're generating a lot of data there, and it gives us the opportunity then to form hypotheses for our research agencies then to test and look into. And so through surveillance and monitoring, for example, we can identify where are those animal disease challenges that we need to then build better vaccines for in our research agencies, or where is that animal's immunity really being compromised that we can help through immunomodulation, or where is that gut microbiome really needing some help to resist disease through nutrition. And all that information can then be fed to our education outreach efforts. And then we have, the circles where, again, we conduct monitoring surveillance to see if, that education outreach is taking, and then do more research so that we're slowly trying to fill in the gaps of that confusogram to help find answers because it's such a, broad area to cover. And so with that, also another example is NIFA, our National Institute of Food and Agriculture's AFRI program, which is the Agriculture and Food Research Initiative. And they fund research, but when the grantees have to not only show the research that they're doing, but they also have to describe the education and outreach part of that research, so that we're not just interested in what is the problem or why is it happening. We need to be able to immediately implement the results of that research into an education outreach to help mitigate the problem. So with that, I just want to kind of briefly go over hazard and risk because it really is important, again, to that crucial piece of mitigation. So these are definitions from Codex, and a hazard in reference to antimicrobial resistance is seen as the AMR microorganism and or the resistance determinant. So through surveillance and monitoring, we are generating information on these hazards. However, we need to do the research. We need targeted studies to understand the relationship between antimicrobial use and resistance, the ecology of resistance, attribution. So we really need a combination of the surveillance and monitoring data, as well as the research information and epidemiological studies, all of that feeding into risk assessment. And then risk assessment helps us find proportionate risk management strategies. And a lot of times on this issue, you know, we get very broad, and really the devil is in the details on this issue. And the Codex guideline that Jane mentioned earlier that was published in 2011, the Codex Guideline and Foodborne AMR Risk Analysis, describes an AMR food safety issue as being that bug, drug, food commodity, or species combination. And an example of why it's important, you know, to look at it this way is Jane mentioned the UK economic report earlier, and that study is based on looking at very specific bacteria, E. coli, Klebsiella, and Staphylococcus. And then it's very specific health conditions, MDR, TB that was mentioned earlier, HIV, AIDS, malaria. And so in order to, you know, have mitigation, you're gonna have very different mitigation strategies depending on that bug drug species combination. And so that's really kind of just, you know, why we, you know, have to get into the weeds on this issue. So finally, I just wanted to briefly mention our USDA Science Blueprint. It was just released earlier this year, and it provides us with a roadmap to guide our science collaborations over the next 5 years within the department, but also with our partnering research organizations. And it's based on these 5 programmatic themes. The ones that are in green have AMR components. So for example, the sustainable ag intensification, the objective under it that's related to AMR is generate fundamental knowledge and tools that can later be applied to improve food animal production and protection systems, including One Health research, such as AMR. The food, nutrition, and translation, the objective for that one is to generate fundamental knowledge and tools that can later be applied to improve food safety and food security, including One Health research, such as AMR. The strategy for that being to conduct research, gather and analyze data on the effectiveness and costs of various food safety interventions and reducing the contamination from pathogens, antimicrobial resistance, toxins, and chemical contaminants. And then the ag science policy one is really across, and it's for supporting science-based policy decision making across agriculture. So that completes my presentation, and I'll stop there for questions.
I have a question, Nina. Hi, thank you for the presentation. I really liked the last slide where you were talking about the sustainable ag, and one of my questions relates to that. Can you tell me, I have a question about how much the large commodity food production contributes to AMR versus the local food production, smaller scale agriculture, because it has also implications for global, you know, for different communities and global health. And I was wondering if the USDA has quantified the risk that comes from those 2 different types of agriculture, the large commodity versus the the smaller scale agriculture. And the question is related to that is I know that small farms don't fall under the same regulatory environment for food safety as larger farms. So that's another part of that question.
Yeah, no, that's a really good and important questions that's getting asked a lot. And right now, we don't have any data supporting that one production system contributes more to AMR than the other production system. But yeah, right now, we don't have data either way to tell us that, but thanks.
Thank you.
Andy has a question. Andy.
Yeah, hopefully you can hear me this time, correct?
Perfect.
Outstanding.
Perfectly.
Yeah, thank you very much. And are there other countries that are doing a particularly good job at applying the science to combat AMR as it pertains to animals and agriculture?
So yeah, I mean, that's a good question. I think, you know, it depends on your definition. And the problem that we have with agriculture is not only do we have numerous species that we're dealing with, we have numerous production systems, and there's different species in different countries, but there's also different production systems in different countries. So what one country is doing in one country may not be applicable to another country. So that's, you know, really, that's why it's really kind of helpful, you know, to have a bit of a domestic focus, I think, for this group to kind of understand in the US, you know, what are our risks and what is useful and helpful here, instead of going to country by country comparisons, just because agriculture varies so much. But I'd like to hear, you know, if any of my colleagues from USDA on the phone have other thoughts, or others.
While you're waiting, maybe I could rephrase it a little bit. So if we take some dimension that might be a across the board useful activity, like let's say surveillance of you know, quantity of antibiotics used, you know, agriculturally or in animal health. Once again, are there lessons to be learned from experiences in other countries? Thank you.
Yeah, so that's another important question. And there's, you know, the quantities is something that's extremely difficult to understand. What most countries have is sales data, and it's extremely difficult to get to use data from sales data. And we collect sales data, and my colleague from FDA that's speaking tomorrow may be able to speak more to that. There are some countries, the Nordic countries, that are able to collect more use data, but it's difficult to compare across because we also have different regulations for some of these drugs. So an example is about 1/3 of what we use, of what we're selling for use in the United States comes from the ionophore class, and it's considered a non-medically important antimicrobial and regulated that way in the US. And in other countries, it's not regulated as an antimicrobial drug. It's considered a feed additive, and it's not going into their accounts. And so trying to compare countries on amounts is really, you know, it's apples and oranges. But open to hear from other colleagues on the line if they've got more to add. Thanks.
This is Lynn Philpy from HHS Office of Global Affairs. I'll add to Nina's comments a little bit because she's absolutely right that it's very difficult to compare apples and oranges when we're comparing different countries' systems and methods. But I do think there are some best practices out there that we can learn from, and we do. And one that comes to mind for me is Japan. They do a risk analysis similar to what we do. They also put more responsibility on the veterinarian to complete the risk assessment. And I think that's something that they're much smaller than we are. They have a smaller agricultural system than we do, but it works for them, and there are things there that we can learn from. Also, in the G7 under Germany's presidency, we did put together a book of best practices, and it's a little dated at this time, but there's quite a bit in there on agriculture that we've certainly looked at, and we certainly discuss with our global partners and think about what we can learn from them and what they can learn from us. And in addition to that, there's the IACG recommendations that Jane mentioned earlier, and those really took a global look. Some of them we've already done, some of them we're in process of working on, and some we either don't have a mandate because they would be a state's responsibility, or we don't have resources, as some of my colleagues talked about earlier. So we can learn from some of our global partners, we do, and then they also learn from us. So we do have some really good task forces, working groups, and places where we can have those conversations and do that work.
So I know we don't have a lot of time, and I don't want to cut into Jane's time. So I'm actually going to put out 3 questions, but I don't really expect you needed to address all of them because it would probably take too long. But I think they're questions that we will want to come back to. And they're kind of in levels of granularity. The first is just in terms of, as we're defining our scope, a lot of the emphasis from USDA is understandably on animal agriculture and especially livestock. But we're also have some interest in the use of especially antifungals on crops. And that specifically relates to the Candida auris issue that we may include in the committee's deliberations, which is at least believed to, the resistance has believed to have arisen from the use of fungicides on crops. Being from an apple growing state, I know they use a lot of fungicides on crops. So part of that would be just understanding our scope as to whether we are restricted, we're going to restrict ourselves essentially to animal agriculture versus the impact of the use of antimicrobials of different types on crops. So that's one. And again, I'm not expecting you to answer all of these. We don't really have time for that. The second is the impact of the differentiation between regulation on antimicrobials versus what's being driven by consumer choices. You know, I know USDA does work quite a bit with consumer choice, and obviously we've seen at least a lot of marketing in terms of antibiotic-free production of animals. So I think that's an area we'd like to look at, regulation versus consumer choice. And then more granular, at a more granular level, just to put these questions out there, you know, there's a lot of talk about not using medically important, human medically important antibiotics in livestock, but there's also the concerns about cross-selection, even though it may be, and that may be direct cross-selection for similar classes of antibiotics, but also plasmid-based, that you're selecting because you're getting multiple antibiotics carried on the same mobile genetic element, that you end up with a selection using a medically, what we might call a non-important antibiotic, but ends up creating selection. So those are, I think, 3 questions. I'm just putting them out there. I don't think we have time now. We're going to move on to our next talk, but I think I'd like the committee to think about those, and we'd like to come back to you for some of your input on those 3 questions. So I've got them written down in case you didn't get them. So we will be able to come back to those. So thank you very much. Jillian, I'm going to turn it back to you.
Sure thing, and I can just remind people that we do have a longer Q&A set aside tomorrow, so we can come back to some of the hands that are raised. So our next, we get to hear from Jane Nisley again, Program Officer from National Institute of Allergy and Infectious Disease. Jane, do you want me to run your slides?
Great, thanks again. Sure. I'm back.
Are they up?
Thank you, yeah. So this time I get to talk to you about what I do on a more day-to-day basis, which is NIAID support for antimicrobial resistance programs. Next slide, please. So just to remind you, the CARB National Strategy and Action Plan, I'm showing the 5 goals here. And our main role at NIH and NIAID is goal 3 on diagnostic development and use, and goal 4 on countermeasure development. So antibiotics, other therapeutics, and vaccines. We play a little bit of a role in goal 2 and goal 5. Of course, we have many international collaborations and things we do internationally, but I'm going to focus on diagnostics and countermeasure development. Next slide, please. So this is our own guiding document, which is available on our website listed here. We first put out this sort of antibiotic resistance research framework in 2014, and we recently updated it with public input. It lays out our approach to basic translational and clinical research to develop new ways to diagnose, prevent, and treat resistant infections. Gives some really nice examples of things that we have supported in the past, and also lays out 7 strategic approaches to antimicrobial resistance research. And those include things like leveraging data science to address AR, reinvigorating gram-negative drug discovery, and optimizing the use of existing antibiotics. So feel free to check out that report. Next slide, please. So as I'm sure you're all familiar with NIH, we have our intramural program, of course, but then what we're probably best known for is our basic research grants. And, you know, we have hundreds of projects that are focused on basic research to address antimicrobial resistance on topics such as defining novel targets for countermeasures, characterizing resistance factors, understanding pathogen virulence and host pathogen interactions without an immediate aim of developing a countermeasure. But this is really the innovation base upon which all of our countermeasure development rests, and a really critical aspect of our approach to CARB. Though, of course, much more difficult to quantify, you know, success. Next slide, please. Complementing these programs for basic research, we also have several other programs focused on genomics and functional genomics, structural biology, bioinformatics, and systems biology. And our structural biology and bioinformatics programs are able to provide services to the research community in those topic areas. So for example, the structural biology centers can determine protein structures that may be of interest for drug design, etc. The bioinformatics program can develop new bioinformatics tools that can be helpful for antimicrobial resistance. Next slide, please. In terms of diagnostic development, I already mentioned a little bit about this and the importance that we give diagnostic development, and we support this primarily through grants, and we have issued quite a few targeted funding opportunities over the past several years focused on developing new diagnostics. There's also strong representation of diagnostic technologies in our small business grant program. And we've supported novel platforms and novel technology development and species identification and antimicrobial susceptibility testing. Some of our recent solicitations have focused on rapid phenotypic antimicrobial susceptibility testing directly from a clinical specimen. So some of them get sort of specific about the specific clinical needs that we hear from clinicians about. I'll also mention our antibacterial resistance leadership group, which is our major clinical program on antibacterial resistance. They also have a strong presence on the diagnostics front. They, a couple of years ago, pioneered the use of a master protocol approach for diagnostics, allowing them to collect data that enabled the FDA clearance of 2 diagnostics for detection of extragenital Neisseria gonorrhea and Chlamydia trachomatis infection. So this is a very efficient approach to diagnostic development that they are hoping to utilize again in the future. They have a project that is focused on host-based gene expression to distinguish viral from bacterial respiratory pathogen. So this is a really promising technology that could help make those difficult decisions about whether or not to prescribe an antibiotic. They provide resources for diagnostic developers such as well-pedigreed clinical isolates. And they also have supported a couple of clinical outcome studies. So this is looking at once a device is cleared by the FDA, doesn't make an impact on clinical outcomes, on economics, on time to effective antibiotic use, etc. So these questions that clinicians and clinical micro labs really care about when they go to adopt a new diagnostic test and order a new diagnostic test. Next slide, please. I mentioned already our diagnostic prize competition. So this was a key feature of the original CARB National Action Plan. It was a multi-phase competition, $20 million total, but some of that money went for prototype development along the way to some of the semifinalists. The winner of this prize was recently announced just in August of this year. And it went to Visby Diagnostics for their diagnostic device, which is a patient-side disposable molecular PCR diagnostic device for Neisseria gonorrhea and resistance markers. So it's not FDA cleared yet, but the hope is that this will be very useful in clinic kinds of settings and will enable the use of oral antibiotics such as Cipro, which are not currently recommended due to resistance. Next slide, please. So for antibacterial development, I certainly don't have time to walk you through everything that we do. We have hundreds of projects on antibacterial development and new therapeutics. We've had numerous targeted funding opportunities and also workshops, particularly focused around some of our non-traditional therapeutic approaches. Where we're focusing now is innovations on existing drug classes. Well, that's where we have been focusing because that's kind of an easier thing to do, is to develop new members of existing classes that circumvent the resistance. And we have some great success stories there, including novel tetracyclines such as arabicycline that was recently approved for complicated intra-abdominal infection. NIAID supported the foundational chemistry work that allowed for the development of those novel tetracyclines, as well as some of the preclinical support for those novel tetracyclines. So that's an important area, but where we're really starting to focus now a bit more of our attention is on, really, can we generate new classes of antimicrobials? That's very difficult to do, as well as non-traditional therapeutic approaches. And I'm going to go into a little more detail. Next slide, please, on those. So one example of a new drug that we consider a success story of NIAID support and handoff to late-stage development partners is cefepime taniborbactam. I'm probably butchering how to say that. It's being developed by a company called Venatorix. And what it is a novel beta-lactamase inhibitor that targets both the serine beta-lactamases, such as KPC, as well as the more difficult to target metallo-beta-lactamases, such as NBM. And it's combined with a cephalosporin, cefepime, for the treatment of carbapenem-resistant, both CRE and carbapenem-resistant Pseudomonas aeruginosa. NIAID has supported this extensively for almost the past 10 years through numerous SBIR grants, as well as product development contracts. We supported the discovery and preclinical development of the beta-lactamase inhibitor, as well as the preclinical and phase 1 clinical trials of the drug combination. And we have successfully transitioned to this program to BARDA and DITRA for advanced development, and GARD-P is now helping to support a global phase 3 trial investigating safety and efficacy for complicated urinary tract infection. Next slide, please. So I mentioned our priority on discovering new classes of antibiotics, and this is particularly an acute need for gram-negatives. This comes from the Pew Charitable Trust report that I mentioned on gram-negative drug discovery. It's particularly challenging to discover new classes of drugs for these bacteria because the chemical properties that will get you through the outer membrane are different from the chemical properties that will get you through the inner membrane. So this has posed a challenge. If you do a drug screen using a library for both gram-positive and gram-negative, you'll get many more hits for gram-positive. bacteria than gram-negatives, they also express a large number of efflux pumps. So even if you get in, you might not necessarily stay in. So in addition to the sort of preclinical development support that we provide, we launched a program to develop tools to advance therapeutic discovery for select antimicrobial resistant bacteria, so focused on these penetration and efflux problems. And recently we had reviewed a chemistry center for combating antibiotic resistant bacteria, and hopefully that program will be launched in the next several months. And the aim of that program is to develop a library that has a better chance of hitting specifically these gram-negative bacteria. What we see is that most of the libraries that tend to be screened have targets that are for eukaryotic cells, and it's just not the same kind of properties that are needed to get access to the gram-negative cell. And we also had a workshop along with the Pew Trust about this issue. Next slide. Non-traditional therapeutics, so this is a really broad and interesting and growing area. So shown in the top right is a bacteriophage. This is obviously a very old potential therapeutic and still used in parts of Eastern Europe. It has experienced a growing resurgence in the West via compassionate use cases where patients have had multi-drug resistant infections and have applied for compassionate use to use phage therapy. And many of these cases seem to be success stories. They're uncontrolled. We don't really know what they mean. We're trying to launch some clinical trials, but at the same time, we recognize that there are a lot of basic and translational gaps that we don't understand about these. So we recently launched a new program on understanding phage biology to support the development of bacteriophage therapy that we're hoping will help answer some of those questions. Also shown on this slide is a monoclonal antibody. This is actually an antibody targeting Pseudomonas that we contributed to a phase 2 trial for. So they're one of the more advanced of these non-traditional therapeutic areas and could be useful for prophylaxis in cases where we don't have a vaccine, which I should mention is most of these difficult hospital-acquired pathogens for a variety of reasons. We're not giving up on vaccines. We have had some initiatives on those and have supported them in other ways, but some really challenging problems there. And then down in the bottom is a depiction of a live biotherapeutic product. So this is a consortium of live organisms, mostly bacteria, that are given as a therapeutic or preventative approach. And this is based on the success of fecal microbiome transplant in treating Clostridium difficile. So there's a growing number of companies that are looking to create things that are kind of like a probiotic, except they have a lot more rigorous safety and efficacy data around them and can actually be approved as therapeutics or prophylactics. Next slide, please. So in addition to the grants that everyone is familiar with, we also provide support for product development through these product development service contracts. These are available to the global research community. You don't have to have NIAID funding to access these services. And they're meant to fill gaps in product development pathway. So we can do everything from in vitro assessments of antimicrobial activity to animal models, pharmacokinetic analysis, toxicology analysis, manufacturing, GMP manufacturing, vaccine services for testing and manufacturing, free of charge. And so this isn't meant to support an entire development program soup to nuts, but again, to provide key data or materials to allow a researcher or a company to move to the next step. We can also establish animal models in response to needs from the scientific community. And I put on this slide, we also have a contract to support phase 1 clinical trial testing. This concept just went to our advisory council because it's up for recompetition. And so in the future, we would expect that this will actually include phase 1 and some phase 2, as well as vaccine and therapeutic early phase trials. And again, free of charge for these services. Next slide, please. CARB-X was already come up. I'm guessing Mark is gonna really hit it hard. So I will just glaze over that this new global public-private partnership is breathing new life into the antibiotic development pipeline. And they have a really exciting array of different kinds of products and non-traditional therapeutics and new classes that they are supporting and have supported over the years. Next slide. Finally, I'll end with the Antibacterial Resistance Leadership Group. This is our major clinical program focused on a wide array of topics on antibacterial resistance. It's really up to them to define their research agenda and their focus areas. They recently received a renewal earlier this fiscal year, and we maintained their broad scientific scope and flexibility to respond to new priorities that may arise. They have a mechanism to solicit ideas from the global research community via their website, and they are able to provide advice to companies on clinical development of drugs and diagnostics, which has been very valuable. They have focused on resistant gram-negative studies, diagnostic studies I mentioned, innovative products, so they're trying to get a phage therapy trial underway. It's challenging. Pragmatic and strategy trials, and innovations in statistical methodology to help advance the way that we do clinical trials for antibacterial drugs. And finally, mentoring. They have a really exciting fellowship program and early stage investigator seat grant program. And I believe that is my, so my last slide just has some resources. NIH has a database of all funded projects, which you can search in many different ways, so that may be useful. And all the funding opportunities that I mentioned can be found at this link on our drug resistance website. Thank you, and happy to answer any questions.
Lefteris, it looks like you have a question.
Yeah, thank you. I would appreciate some granularity on clinical trials and how you see the role of the Institute in facilitating clinical trials. Clearly, you are forced into this area because of the need, but how do you see that, and what are the headwinds that we're facing? Thank you.
Sure, absolutely. So I think our Institute, on this topic anyway, we focus primarily on phase 1, some phase 2, and then phase 4 trials or strategy trials of how to optimally use existing drugs. That's in addition to diagnostic trials. And so that's our focus area, and we have a number of different ways to achieve those. The contract-based mechanism for early phase studies that I mentioned, that's really popular with companies because they can come in and get a phase 1 trial done for free. The Antibacterial Resistance Leadership Group they have done some phase 1 and phase 2 trials, but they're really focused on providing data that will be actionable to clinicians. And so they really like these strategy trials that will tell a clinician, so I'll give you just a few examples of the kinds of trials that they've done. They recently completed a trial in pediatric community-acquired pneumonia looking at a short course of therapy compared to the standard course. And so the idea there is if you can give less, you should, because we know there are side effects with antibiotics. We know it alters the microbiome, et cetera. And so that trial has finished enrolling, and I urge you to go to ID Week to hear the results. Another one that they are developing is looking at dalbavancin compared to standard of care in treating staphylococcal bacteremia. So dalbavancin is a long-acting antibiotic that means you do not need a PICC line in order to use it. And so they're looking to make sure that it will work in those patients. So those are just two examples of the kinds of trials that ARLG does, but we can certainly do the more straightforward phase 1 and phase 2 trials as well. And then we look to our partners at BARDA and GARDP and others to fund those phase 3 pivotal trials.
Trying to see if any other questions. Just one before we run out of time and move to our last presentation. Can you comment a little bit on, you mentioned the duration of course of antibiotics related to, for example, C. difficile risk. Can you comment on the use of effective or ineffective antibiotic regimens on development of C. diff? What kind of studies are going on that perspective?
Yes, let me think for a moment. C. diff, we
or
have
we
these
come back
artificial
to
silos.
it.
No, we have these artificial silos in the government. It's in a different branch, so let me just pull that information up. So we're actually doing some fecal microbiome transplant studies in C. diff, and we've also supported some studies on C. diff vaccines, I believe. And as well as new classes of oral antibiotics for C. diff that are not systemically absorbed. In terms of studies that specifically look at the risk of antibiotic treatment on the development of C. diff, I think we have conducted some of those trials, but I would have to get back to you with specifics. I think we know there's very good data to support that, especially for certain classes of drugs, that it is definitely a predisposing factor.
Yeah, I would be interested in what the granularity of that data is in terms of classes and whether those are ones to which there is broad scale resistance already present that results in a longer course, or some of the complexities of that. But we can come back to that. Thank you, Jen.
Sure. Thanks.
Very much. Joanne, I think so we don't want to cut into Mark's time. Let's get him started right on time.
Absolutely. Mark, do you need me to advance your slides, or is that something you're going to do?
I'm going to try and do that. Hopefully everybody can see my slides now.
Yeah.
Perfect, great. Let me move this out of the way. So first off, thank you so much to the committee for inviting me to come here today and be able to present on BARDA's efforts under the National Action Plan over the last 5 years. And I thought really to kind of start out this talk, it would be useful for me to, now I'm having issues advancing.
You have become very faint, Mark.
Yeah, I'm trying to advance my slides and now
okay, well, you're back.
Oh, there we go. Okay. So I thought it would be useful to kind of talk a little bit about the background of BARDA, where we sit within HHS, as well as what our mission space is with antibiotics, before going in and talking about the National Action Plan and how we're really evolving and working within that space. So to start with, ASPR really has this mission to save lives and protect Americans from 21st century health security threats. ASPR's mission really is focused on being the leader within the public health response for a variety of emergencies. We've been hearing a lot about ASPR currently as it comes to coronavirus. BARDA is an operating division within ASPR, and our focus really is to be the R&D arm of ASPR and provide all the medical countermeasures that it needs to support its mission. So how do we do that? Well, we enter into these public-private partnerships to accelerate product development, and we are focused within several key areas. One is chemical, the other is biological, radiological, nuclear threats, pandemic influenza, and emerging infectious diseases. And of course, that encompasses things like Zika, Ebola, as well as coronavirus. And by accelerating these products, we're really focused on getting these products from phase 1 all the way through phase 3, and hopefully product licensure. And our model that I highlight here is really successful because we are able to provide multi-year funding that is non-dilutive to product developers. We also provide subject matter expertise, have a variety of flexible, nimble authorities that enable us to work with companies, and at the same time have a variety of core services that ultimately enable companies to be successful. Not very unlike what NIAID provides. Historically, BARDA has justified its investment within the antibiotic space, really among two key lines. One, of course, is the biological threats, but the other is a little bit more subtle. And if we look across all of the threats that BARDA is responsible for addressing, whether or not that threat is a CBRN threat, pandemic, flu, or an emerging infectious disease, we are going to need antibiotics to really help that patient recover in the hospital and healthcare setting. It's not enough just to treat that initial causative agent of the threat. We need to be able to have the resources to be able to make sure that patient can have a full, healthy recovery. When it comes to AMR, we definitely consider this a national health security threat, particularly when it comes to those patients that are recovering from CBRN threat. The lack of an effective antibiotic can definitely impede our ability to respond to these public health emergencies, definitely driving up costs, driving up patient contact time, requiring more PPE and more physical disposable resources to go into healthcare. The most challenging forms of antibiotic resistance occur within the healthcare setting. As I mentioned in the previous slide, we already are anticipating these patients are going to be within that healthcare setting for a protracted period of time. It's within those settings that we're going to need the best antibiotics to really see patients come through the other side. Now, if we take a closer look at this and start really looking at the pandemics that we've seen most recently, particularly H1N1, all of the data really highlights the fact that mortality and morbidity due to flu-based viruses ultimately is driving up mortality and morbidity is being driven up by bacterial infections. In fact, as you can see in the center of the slide, it's been estimated that 30% to 50% of all deaths from H1N1 in 2009 were really caused by these secondary bacterial pneumonias that were within patients. It's definitely a striking finding and highlights the need for antibiotic development. So where does that really bring BARDA? So the antibacterial branch's mission is to, as you can see here, reduce the morbidity and mortality caused by both biothreats as well as antibiotic-resistant infections following these mass casualty events, or even a disease outbreak. To accomplish this, we definitely draw upon BARDA's model. I mentioned that non-dilutive funding, the subject matter expertise, flexible authorities. All of that comes to bear to incentivize antibiotic development. Now, as Jane highlighted a moment ago, we're really interested in innovative technologies that overcome drug resistance. But at the same time, we're interested in those products that are an evolutionary leap forward from existing products, trying to have a holistic approach to treating patients, whether that's a small molecule, antibody, phage-based therapy, vaccine, microbiomes. We're interested in all of these different technologies. So now for the rest of my talk, I wanted to really drill down on the National Action Plan and how BARDA has been responding to it. I've highlighted essentially the 5 goals that are within the National Action Plan. I will note that the antibacterial branch has really been focused in on goal number 4. We also do speak to goal number 5, and I'll touch on that in a moment. Goal 3, which is focused in on those diagnostic tests, are really addressed by the diagnostic division at BARDA. I won't be focusing on that today. Under goal 4, the US government was called to stand up a biopharmaceutical accelerator. The mission of this accelerator really was to provide non-dilutive funding and resources to support early stage product development. It was noticed that the early product development pipeline was really empty and needed support. So BARDA, working with NIAID as well as the Wellcome Trust, established CARB at Boston University to meet this goal. So far, as you can see in the facts on the slide, it's been amazingly successful. In fact, right now, the slide's already out of date. We now have supported 68 different projects. We have, I believe, 48 or so different products currently in development. And what's important is it's also drugs, but it's vaccines and diagnostics, really supporting, again, this holistic approach to addressing AMR. Now, this brings us to our advanced research and development portfolio. And this really is kind of the major component of BARDA. And as you can see here right now, we have 11 different partnerships supporting 14 different candidates. Importantly, 6 of them are in phase 3 clinical development. And really, this portfolio alone is addressing several different components of goal number 4. One of them, of course, has been discussed earlier, is this transitioning of products from other different agencies within the federal government. And I do want to highlight the fact that we are supporting Venatorix, Taniborbactam, as well as we've supported Academies. That was one of the first programs that actually entered our portfolio for plazomicin. That program is quite interesting because it started out within the DoD and then transitioned to NIAID and ultimately came to BARDA, definitely showing the success of this interagency collaboration. And again, we also supported Tetraphase on their development of cycling, again, graduating this program from NIAID, as has been pointed out earlier. Now, the other thing that we've really been able to do with this portfolio is provide technical services to these companies and technical support. It was another aspect of goal number 4, is to not only provide non-dilutive funding, but also provide technical support to help companies bring their products forward. And that really is what a lot of people call the secret sauce at BARDA, that technical support that we're able to provide. Goal 4 also called upon BARDA to leverage our other transactional agreement, or what we call a portfolio agreement. OTAs are quite important to some companies. It really enables us to support a small portfolio of products at a given company. And importantly, through that portfolio, if any one of those candidates is unsuccessful for whatever reason, if it's technical or strategic, we can eliminate it and either bring in a new candidate into that portfolio or divert the funding that was slated for that original candidate to other candidates that are within the portfolio. It gives an amazing amount of flexibility to both the company as well as the US government. At the time the National Action Plan was initiated, we only had one OTA, and that was with GSK. We now have 5 within our antibacterial portfolio. Those exist with Pfizer, the medicines company QPEX, Roche, as well as Genentech. It's important to note that the Genentech OTA is quite unique out of the 5. This is an umbrella OTA in that it has an antibiotic, but it also has a medical countermeasure for chemical threats, as well as a flu-based therapeutic, addressing multiple spaces within BARDA's mission. Now, speaking to goal number 5, that really talks about these international partnerships. And it's important to note that through that Pfizer OTA, we're able to work with the New Drugs for Bad Bugs program at IMI in supporting one of Pfizer's phase 3 clinical studies. Similarly, as already been mentioned, under Venatorix, we're working with GARD-P on their CUTI study, really bringing about multiple different international funders to coordinate on product development to see success. Now, it's important for us to also focus in and talk a little bit about Project BioShield. This was a contract that we awarded at the end of 2019 to Paratech for amatocycline. This contract is extremely unique to BARDA. In fact, it's extremely unique within the entire antibacterial space. This contract has not only that component of advanced research and development, really providing push funding to push a product forward, but it also has a pull in it. And this is really the incentive that companies start to talk about and really are interested in having. Under Project BioShield, we're able to purchase product and make it available to the ASPR to support their mission. This is really kind of the key component of what BARDA does, particularly through Project BioShield. Ultimately, this is the push that pulls and something that we are extremely excited to be leveraging over the next couple of years, and we'll ultimately be able to see a new award, hopefully in 2021, using Project BioShield. So in summary, it's been an amazing 10 years. In fact, our 10-year anniversary was back in April. And unfortunately, we didn't have any cake or champagne at that anniversary, mostly because we were responding to COVID-19. But what's really important here is that over those 10 years, we've invested $1.5 billion in the development of antibacterials. That's gone to support 25 different products right now. And through those efforts, we've been able to see 3 FDA approvals. And as I had mentioned earlier, we've got 6 products in phase 3 clinical development, which ultimately is really going to speak to the fact that we do see additional approvals on the horizon. I think it's exciting to be able to see these advances and ultimately are looking for that future achievement of additional approvals. Just in closing, BARDA really isn't going to go away. We definitely see the need to continue to incentivize and catalyze antibiotic development, both at that early stage through the late stage, as well as supporting under Project BioShield, post-marketing commitments and procurements of product. Through this holistic approach of product development, are we going to be able to see new products come to market? The next chapter, I think, in the discussion and the challenge is really understanding how we can be successful within that post-approval stage, that post-marketing authorization, so that we can then see products basically be successful. It's that element that ultimately speaks to access for us. The company that goes bankrupt and their product no longer is available on the market essentially isn't helping anyone, and we've suddenly lost access to it. And with that, I'll close and take any questions.
All right, thank you, Mark. Are there any questions from the committee? And I do want to remind the committee, just because we only have a few minutes left, is if you don't have questions now, we're going to have much more time tomorrow to really address questions. So it's really a time to reflect on a lot of the presentations and being able to ask questions even across presentations. The common issues or areas that we want clarified will be important for tomorrow. Mark, I just do have one question, which is, do you have, I'm sure you have data, but is it data you can share on, for us to understand where in that pipeline, what the timeframes are and where things succeed or don't succeed, and any indications why they don't succeed? Because that obviously will help us understand the challenges, the constrictions in the pipeline, and how those have been addressed or could be better addressed in the future.
That's a great question. Yeah, I find that a lot of the early stage candidates are really the ones where we see a lot of attrition. As a program begins to advance and move into phase 1 and phase 2, the rates of attrition definitely start to decrease, mostly because things like toxicity, or safety signals have been identified through those preclinical studies, those animal studies, to really design to uncover all those issues. One of the things that does happen in late stage development is you might see a tox signal that there was just no way to uncover within an animal, and it's something peculiar to humans. That, of course, is very rare, but it does still occur. There have been times where programs have been terminated because we begin to see resistance in the clinic due to the product, and that has driven a late stage termination. I think that the challenge is that there's always going to be this need for additional funding, support, technical services all across the pipeline. And I think now more than ever, that need is starting to grow because these programs are beginning to really be more expensive than they've ever been. And through that process, we're going to need more resources. But at the same time, I think that following product launch, that's another area that is an enormous challenge for both the US as well as globally. As I mentioned, if a product company goes bankrupt, the product is no longer available on the market, suddenly we lose access.
Yeah, and it might, Andy Strigachis has a question here, but and we'll come back to it, but it may be helpful for us to know how the federal funding maps to that pipeline and where it's most critical in terms of development. But I want to go to Andy because we just have a few minutes left.
Yeah, thank you very much. I'll make it quick. Given BARDA's innovation role, are there any new incentives that are being considered on the horizon with respect to antibiotic development that go beyond what has been done and shown to be effective or dismissed? Thank you.
Yeah, absolutely. So as far as research and development, we aren't really considering any sort of new models for the research and development focus. We definitely, of course, are working with our colleagues at ASPE to understand a little bit more and provide insight into potential policy changes or new authorities that could influence or support both product development as well as that late stage space. But at this time, I'm not seeing any new initiatives.
Just a quick follow-up. What about new policies and incentives?
Yeah, the great question. And I'll really have to turn to the policy shop to have them answer that question for you.
And we have a question from Dr. Okeke.
Yes, thank you for the talk. It's a quick one. I just wanted to know what the relative mix of drugs, vaccines, diagnostics in the product portfolio that you have now is, and what's the relative failure rate between the different types of products? Thank you.
Yep, great question. So right now within the advanced research and development portfolio, we don't have any vaccines. Everything right now is small molecules. We are looking forward to being able to bring in a vaccine as well as a novel therapeutic like a microbiome or a phage-based therapeutic. CARB has a much more significant blend of these different products, and unfortunately off the top of my head I can't give you the relative numbers. It's all highlighted on their website. However, then they do have a fantastic blend of both small molecules, vaccines, and diagnostics, and other novel innovative therapeutics. Now, looking at the failure rate within the portfolio, that's a little bit harder for me to answer. I actually haven't sat down and calculated it, to be quite honest. I think at last count, the last time I was looking, there's been somewhere around maybe 7 or so products that have dropped out of the AR&D portfolio, that advanced portfolio, due to one reason or another.
Thank you.
All right. If there's no, we've kind of come to the end of our time with a few minutes left. But I want to thank all of our speakers. I want to remind the committee to reflect on what we've heard today, and we'll hear more tomorrow. But in terms of questions, because this is a great opportunity for us to really understand well the statement of task and how we're going to address these critical gaps. But Jillian, I don't know if you have any more before we close. I think we're ready to close. We're getting close to 10:30, and also I have to go to the bathroom because you can only sit and drink coffee for so long in the morning before biology takes its course. But again, I want to thank everybody, and I will look forward to seeing you tomorrow morning, afternoon, or evening, depending on your time zone. So thank you very much.
You all. Bye-bye.
Thanks, everybody.